Hello, this is Dr. Michael Brown from Rush University Medical Center in Chicago. Here today to talk to you briefly about the management of Clostridium difficile if the test is positive. What do we do next? How do we get to that positive test? And then what are the non-operative managements of Clostridium difficile colitis? So I do want to cover the testing strategies for Clostridium difficile. Mainly because I want us to be sure we're treating a CDI and not a Clostridium difficile colonization, which oftentimes doesn't require treatment, and just make sure nosocomial infections look pretty awful. So we want to make sure we're treating the correct thing here. The way to do that is two-stage testing. So instead of just relying on the PCR, what we want to do is start off with the PCR or nucleic acid amplification test, or a GDH, glutamate dehydrogenase test, both of which are highly sensitive. And if they're positive, then move on to a more specific test so that we can avoid picking up the colonized patients and overtreating them. So the next test in this strategy would be a toxin enzyme immunoassay for toxin A and B. And if that is positive, then you've got a CDI. You've got a C. diff infection. Go ahead and start treatment. You're good to go. If, however, the more specific test, that is the toxin EIA, is negative, you may have colonization, you might have some other cause for the diarrhea. You want to rethink your diagnosis of Clostridium difficile infection. If you're still highly suspicious, even with the negative EIA for toxins, then you might go ahead and treat anyway, but you might be treating colonization, and you don't want to do that. That's not going to be particularly helpful. The other two-stage testing strategy, the one I tend to use, is where I start with the GDH antigen test. I start with a toxin A and B EIA, and then if these are both positive, now I have a CDI and I treat. If these are both negative, I don't have a CDI, and maybe I'm chasing around colonization, or I have another reason for their diarrhea, and I've got to check some other things out. If, on the other hand, we have discordant testing, one of the others positive, we have an indeterminate result, then I'm going to get the PCR as the arbiter of the discordance. And if the PCR NAAT is positive, now I have a C. diff infection. I'm going to head off and treat that. If, on the other hand, the NAAT is negative, that's such a sensitive test, we clearly don't have CDI, and we need to move on to another diagnosis. So that's how we make sure we have CDI. So now we have our CDI. What are we going to do after the diagnosis? We're, of course, going to stop antibiotics if we can. If we can't, so be it. We're going to stop PPIs if we can. If they're unnecessary, certainly we'll want to remove those. Their cause and effect role in C. diff infections is still controversial, but if you can stop them and you don't need them, I do that. Stop nasogastric intubation if you can. It is associated with initial C. diff infections as well as recurrence. So if you don't need it, maybe it's time to lose the NG tube, and then start initial antibiotic therapy for C. diff infection. So what's that? Well, as of June 2021, the American Society of Infectious Disease updated the guidelines with an interim suggestion. And that suggestion is that we switch over from Vancomycin as our initial therapy for non-severe CDI to Fidaxomicin. The reason for this is not better upfront resolution, but reduction in recurrence rates over Vancomycin that were significantly different. Fidaxomicin is 200 milligrams orally twice a day for 10 days, just like the Vancomycin is 125 4 times a day for 10 days. However, Fidaxomicin costs $4,000 for a 10-day course. It can be kind of expensive. So you may not have that available on your formulary. It may not be covered by insurance, in which case your fallback position is Vancomycin. Oral metronidazole, no longer recommended. We're not going to use metronidazole here. It has a role down the road. We'll talk about it later, but right now we're not going to use that any further in initial C. diff infections, just too high a recurrence rate. There are currently no recommendations in any of the guidelines for treatment with probiotics, rifaximin, tigecycline, catazolid, serotomycin. All of these have been used in single center, often small studies, not ready for prime time. Antidiarrheal agents are okay to use in treated patients with non-severe CDI. You can use diphenoxylate to control the diarrhea or other antidiarrheals, and PPIs can be continued if you need them for underlying peptic ulcer disease, bleeding, etc. The first recurrence therapy for a non-severe CDI would be tapering or post-vancomycin or fidaxomicin. And here again, as of a couple of months ago, The American Society for Infectious Disease switched gears and said Fidaxomicin is the way to go. It's now preferred over a pulsed tapered vancomycin approach if it is available and covered by insurance. Fidaxomicin, you can go with the standard dose for the first recurrence, particularly if you went with vancomycin for the first treatment. If you use Fidaxomicin out the gate and you've got a recurrence, then I would use an extended or pulse Fidaxomicin as detailed here. It's the for days 1 through 5, but then you're going to shift to alternate day therapy for days 7 to 25. You want to extend that length out a little bit if it's a patient with higher recurrence rates. You maybe want to stretch it out to that 20-day range. Vancomycin, there's 3 approaches to tapering and pulsing. There's a tapered approach, there's a pulsed approach. There's my personal favorite, which is a tapered and pulsed approach. Complicated, but it works. It's 125 milligrams 4 times a day for 10 to 14 days, then 2 times a day for a week, then once a day for a week, then every 2 or 3 days for 2 to 8 weeks. Again, longer time frame on that pulse if the patient's at very high risk of recurrence. So let's say you're on your 2nd or 3rd recurrence, you want to stretch it out a bit. Oral metronidazole, no longer recommended. We're not going to go there with on our recurrence patients. 2nd recurrence, here we're back to thinking about vancomycin or Fidaxomicin, pulsed or tapered. But here's where you start to think about fecal microbiota transplant. You clearly want to think about it the 2nd recurrence. You definitely want to do it probably at your 3rd recurrence. FMT is preferentially obtained from a pooled stool bank like OpenBiome. You can set up an account with them and get this material. I would definitely go with the pooled stool bank versus single donor samples, which have not necessarily been vetted for pathogens. The patients that the people you're getting the donor samples from might have comorbid conditions that could be problems down the road. Don't use your wife. Don't get the stool from your med students. All sorts of issues there, but I've seen both of those, so that's not a great idea. Don't get the family member to give you the stool because they probably have C. diff spores. So stick with the pooled stool banks that do this correctly. You want to deliver this via colonoscope to the ascending colon or terminal ileum, or you can use oral capsules if you don't want to do the colonoscopy. Enemas is another delivery option if you don't have colonoscopy or you can't get the oral capsules, but both the colonoscopic FMT and capsules are available from many stool banks. Don't give it by EGD, high aspiration risk, and that's obviously a very high complication rate there if you get a aspiration of this stuff. Repeat the FMT for recurrence at 8 weeks. So you can repeat the first one. 3rd and 4th FMTs are probably not going to work. And if you do a 2nd one, colonoscopy is the preferred method. It is safe in cirrhotics. Recent studies showed that. You do have to be cautious in the severely immunocompromised. There have been opportunistic infections after giving patients FMT in the setting of, for instance, bone marrow transplant patients, et cetera. What are the risks? E. coli infection, COVID-19. There's even a question of whether chronic disorders like diabetes or obesity can be transmitted by FMT. Obviously, that'll take probably decades for us to figure out. It's theoretic only. And certainly if you're about to lose your colon, you'll probably put up with that risk, I think. So FMT is definitely something to think about at the 2nd recurrence and definitely the 3rd or hopefully not the 4th. 1st or 2nd recurrence therapy for non-severe recurrent CDI and those who have a high risk of recurrence. Here's another new suggestion that we use Bezlotoxumab. So Bezlotoxumab is a human monoclonal antibody that binds toxin B, prevents it from entering the epithelial cell layer, and preventing, therefore, colonic cell damage. It is now recommended as co-therapy for the 1st or the 2nd, or, if you get a 3rd and 4th, you certainly want to try the Bezlotoxumab to reduce recurrence. It's a 10 milligram per kilogram dose, IV, given once. It can be used up front in severe CDI and fulminant CDI. You do want to avoid this, though, in patients who have CHF or other severe underlying cardiovascular comorbidities. And just like Fidaxomicin, cost is a limiting factor. This is $5,000 a dose. You probably don't have this on your formulary. Most P&T committees aren't thrilled to have to purchase this stuff, but it is now recommended by the most recent guidelines for reducing recurrence in patients, particularly with their 1st or 2nd recurrent C. diff infection, and those with severe and fulminant disease. What happens when everything fails? You've tried 3 different approaches to antibiotic therapy and tapered and pulsed, and you've given 2 FMTs, and they still keep coming in with C. diff. One thing I'd really remind you here is make sure it is a C. diff infection and not C. diff colonization that you're chasing around. I've seen that happen a couple of times. But if it is a C. diff infection and you can't clear it, then indefinite therapy with 125 milligrams of vancomycin every day indefinitely is the way you have to go. If you have a patient who has a lot of recurrences or high risk of recurrence and you're coming up against some subsequent antibiotic use, let's say for an impending elective surgery, then consider oral vancomycin prophylaxis, or OVP. That's going to be 125 milligrams of oral vanco daily during systemic antibiotic use and for 5 days after cessation of the antibiotic use. So on to severe CDI and fulminant CDI. How do we define these problems? The criteria predictive of unfavorable outcomes are used to define severe CDI, and that is a white blood cell count greater than 15,000 and a serum creatinine greater than 1.5 milligrams per deciliter over baseline. Low albumin less than 2.5, high fecal calprotectin greater than 2,000 are also suggestive of severe disease. But the real predictive ones, the only 2 you really need are that white count and the serum creatinine. Fulminant CDI is the criteria for severe CDI plus hypotension or shock or ileus or megacolon. Any one of those gets you the definition of fulminant CDI, and treatment is different. So for severe CDI, you're back to Fidaxomicin and Vancomycin. The standard doses will be fine up front. 200 milligrams orally twice a day for 10 days, or 125 4 times a day for 10 days for Vanco. Interestingly, the guidelines do not have a preferred one, Fidaxomicin or Vancomycin, for severe CDI, which I find interesting. But pick your antibiotic there. Probably Vancomycin is going to be a lot cheaper. What about fulminant CDI here? It gets very different. Patients with fulminant CDI should get very high dose vancomycin, 500 milligrams orally every 6 hours. By the way, orally, remember, orally, for the first 48 to 72 hours. The only parenteral drug you can give here is going to be metronidazole at 500 milligrams every 8 hours. With an ileus, you can add vancomycin enemas, 500 milligrams every 6 hours can help out. FMT should be used in these patients with severe fulminant CDI who are refractory to antibiotic therapy after 2, 3, 4 days, and when deemed poor surgical candidates. And at any time point, you could consider a single dose of Bezlotoxumab to help you out. If that doesn't work, on to surgery. That's been covered by Dr. Gantt. I won't go into it. It's total colectomy versus diverting loop ileostomy. Mortality rates for the 2 vary among studies. So basically, it's surgeon's judgment and experience on this as to which approach is taken, and I won't delve into that. So in summary, you want to test with a 2-stage testing. If you want to, start with the PCR or the GDH and follow that up with an EIA test for toxins. If they're both positive, you're on your way, treat for CDI. If the EIA toxin test is negative, you might have a C. diff colonization. You sort of want to rethink things. Alternatively, you can do what I do, which is the GDH and the EIA toxin initially. If they're both positive, great, got a CDI infection. I'm often treating that. If they're both negative, better yet, they don't have a CDI infection. I have to figure out why they have diarrhea, but it's not C. diff. And if they're discordant, then I'll let the PCR determine the need for therapy. If it's positive, they get it. Treatment, again, initial CDI, the current guidelines say Fidaxomicin over Vanco for 10 days. The treatment of the first recurrence, again, guidelines suggest Fidaxomicin taper, therapy over vancomycin taper, pulse therapy, plus minus at this point Bezlotoxumab to prevent recurrence. Recurrence CDI times 2, again, FMT now starts to come into the mix versus repeating the taper pulse therapy of either Fidaxomicin or Vanco. And then here's our Bezlotoxumab coming in for 1 quick dose. And then severe CDI, Fidaxomicin or Vanco for 10 days oral, your pick, plus minus Bezlotoxumab. And then fulminant CDI, you IV fluids, high-dose oral vancomycin, IV metronidazole, Bezlotoxumab, vancomycin enemas, fecal microbiota transplant if all else fails, surgical intervention if that fails. There you're going after everything. So that's my quick review of testing and treating for Clostridium difficile infection from a medical standpoint. These are very up-to-date guidelines just as of about 2 months ago. So you're on top of it. Thanks for letting me share that with you.